Hey, we're back. This is Move to Improve. I'm Dr. Jurgis. We got Dr. Alex Fitzwich here and Dr. Greg Uchas. So today we're talking mobility versus stability. And I really like this breakdown. That's something that Gray Cook kind of laid out in the FME Bible. And it's basically, if you take the human body and you reduce it to two fundamental factors, I guess you could say, there's mobility and stability. It's a balance of two things that keeps us moving, right? Can't have too much of one without the other, right? You guys want to elaborate on that for a second?
Yeah, so the example I always use is like WD-40 and duct tape. So a lot of what we do, like adjusting, muscle work, mobilization, that's like the WD-40, right? Something doesn't move enough, we make it move more. But the piece that a lot of people don't take into account is that duct tape or that stability. And so if something already moves too much, how do we make that tighter? How do we make it stronger? How do we make it more stable? And that's where a lot of people kind of don't respond well in their rehab, right? They'll get better once they're moving a little bit better, they're not as stiff and sore, but long term, to prevent injury, we want to work on that duct tape piece, that stability.
Mm-hmm. Yeah, and the interesting thing is, some body types are just going to be more unstable and could benefit more from the stability. People that you just are loose in the joints, their collagen is much looser, and you could probably identify yourself if you're one of those people. And then some people are just so stiff and just they need mobility for whatever reason. Their body type is rigid, right? But the interesting thing is that you'll have an area of the body like the core where you're gonna want more stability, more rigidity to keep things stable. But then there's adjacent areas where the need is for more mobility, like the hips and the thoracic spine. And you can't have one without the other.
I agree. So I love the duct tape, by the way, versus WD-40. That's actually really good.
It is, yeah. And I explained like what we do is mostly like WD-40, and then like what Melissa does is mostly duct tape, and you need a combination of the both, sometimes in different areas.
Yeah, that's pretty good. So I would agree. So let's talk about the hips. So I wholeheartedly agree. So people get stiff and tight all through their hips. Okay, is that a mobility or stability issue? Well, the immediate issue that we're dealing with is Kairos, is that's a stiffness thing, right? It's a mobility piece. You got tension all through the hips, so we're doing all our myofascial work in through the hips. We're finding out all the tight tissues and tension, the myofascial strain on the area, and we're loosening that up. We're loosening up the articulations because there's scar tissue built up. There's irritation there because they've irritated the joints. So you have all this. So we're working on the mobility piece. The question is why is it stiff and tight? And it's always a freaking stability piece. It's like they're moving wrong. They're not contracting the muscles. They're not doing the movement pattern the way they need to do the movement pattern. So now when they're in an inefficient system, the inefficient system gets overworked and then everything gets stiff, right? So I agree. They go hand in hand. But really, if we can work on that stability piece, because everybody lacks. Everybody wants to go home. Everybody wants to stretch. Everybody wants to foam roll. They want to go and see their practitioner. That's all. It's
easy.
Yeah, it's easy. You can go get the passive care. It's like, you take care of me and do this. But the reality is, if people are more stable and people are working on a stability piece, when people are working on establishing proper movement patterns and ensuring they've got upper and lower core stabilization and engaging that properly when they're moving, or scapular stabilization, etc., all these things, then mobility becomes less of an issue here, right? Because they tend to be healthier and not have these issues coming in. I do like Gray Cook's stuff, like where he'll basically assess, okay, is this a stability or a mobility issue, right? And you just determine it through testing, and you say, okay, if this is a stability or this is a mobility issue, now we need to get in there and we need to do our work, right? Mm-hmm. And we need to provide that mobility back. And then the patient needs to provide that stability overlay, right? So it doesn't keep coming back. Because there's some patients that I treat all the time for the same stuff on, and that's the mobility piece, because they haven't provided that stability, right, to the system. So they just keep smashing the same joints, the same muscles, the same ligaments, tendons, myofascial tissue, etc., right?
Yeah.
That's my take.
No, it's a good point, and it is. I think the go-to for a lot of patients is thinking, "Oh, I need more mobility. I need to stretch more. Stretch more for everything, right? Do you have any stretches you can give me?" It's like, okay, but you're probably going to get more benefit out of trainings for stability. And a prime example is the old hamstring stretch, where everybody wants to stretch their hamstrings, but the reality is you don't have the mobility because your core isn't stable enough to anchor in your hips to allow them to move into their full range, right? So if you had the core stability piece, you wouldn't need to stretch your hamstrings every day and still gain no range.
Yeah, just to touch back on like the Gray Cook idea of figuring out if it is actually the muscle or the joint, because sometimes it is, or if it is more of a stability piece. Like with that hamstring example, if you physically are stretching the hamstrings with a straight leg, there will be a point where it can't go any further, and that's like the physical length of the muscle that's limiting you. But with a lot of those patients, if you get them, you either stabilize their pelvis with your hands, give them some external stability, get them to brace their core properly, or any of these other things to provide more stability, then they'll have like dramatically increased range, like just like that. And that's because that hamstring is tight because of pelvic position, poor core bracing, or any of these other factors. It's not because of the meat of the hamstring that's like actually too tight. You don't actually have to stretch it.
Yeah, that's a cool point to bring up with patients, or to just passively move their leg all the way up and be like, does that hurt? Do you feel like you're gonna tear? And they're like, no, it feels fine.
Yeah.
It's like, well, you have the mobility. You don't have the muscle control to take yourself into that entire range. And so the stress really becomes, if you have the range now, then you need to be able to keep it stable and keep it strong within that range, or else you're just gonna lose it again.
Yeah. So what's the take home? I guess the take home is that both are really important, right? We're the mobility piece primarily, right? And helping people, but really the focus is we got to teach people to engage more in that stability piece, right? It's like we know this concept when it comes to osteoarthritic change, right? Like the whole concept of osteoarthritic change, the literature is telling us now that, low bearing joints like a knee and hip don't really absorb force, right? They redistribute force. And so they really don't break down and become arthritic unless either A, you've damaged those joints and now there's some sort of structural difference to that joint than what it was made for, or B, you're moving wrong, right? So it's the muscle dysfunction theory of osteoarthritis. So if you're moving inefficiently, you'll start to load that joint inappropriately. And so what happens is the body says, holy crap, we got some stuff going on here. Okay, so what we have to do is we have to adapt. So let's make the bone thicker and stronger. So it becomes thicker and it starts to pancake out, right? Your bone growth too, because it's absorbing that force, it's trying to respond to that increased stress. Well, that's osteoarthritic change, right? That's sclerosis, that's osteophyte formation. So if we can get people to move right, then we're not going to degrade those joints. So that comes into the teaching them how to move properly, getting rid of the mobility issues, and and getting them stabilized so that they can move properly, right? So the take home is that we need to teach people to engage more in stability type exercises and make sure they're educated and aware of what it means to move properly, right? And giving them those stability exercises to get there, right? That would be the take home from my thing. I wanted to challenge you guys on this, so let's make it a hypothetical professional hockey player damages his MCL, and immediately the healthcare people with the team, doctor with the team, puts him in a stability brace and says, you leave this on for 3 weeks. And then we'll so they get an MRI. They find out that, say, 80% of the fibers are torn. There's only 20% of the MCL hanging on. And they put them into a stability brace right away, immediately, like a Don Joy break or something like that. Say 3 weeks, you're wearing this thing for 3 weeks. Is that the right approach for this type of injury? It's an interesting question because I can see why they do it, right? But like, it's a liability thing. You want to tighten up the MCL. So what are the arguments, guys?
Yeah, I think that number one argument, like in that hypothetical example, you want to protect your assets as much as possible. It's way better for a guy to be in a knee brace for 3 weeks than to tear his MCL and have to, do surgery, do rehab, all that kind of stuff. Like, again, I totally get that. The only issue is that the cause of that in hockey's a little bit different, right? Things just happen in hockey. Like, you can, even if your knee's stable, you can still tear your MCL. But in general, if there was more stability in that knee already, then there'd be more protection and probably less stress on those ligaments. And so when you introduce that external bracing mechanism, then you teach the body to kind of rely on that, and it doesn't have to stabilize the area as much as it would.
Yeah, but we're talking hockey. We're talking like another hockey player fell on you, right? And totally tore that MCL, right? So, and now they're saying, okay, 3 weeks, you're braced up.
Yeah. So the thing that I always remind people is that, you sprain a ligament or whatever you injure, the best way for it to heal is to heal under some amount of stress, whatever that optimal amount of loading is, and it's going to be not that much to begin with, but your body's just going to lay down connective tissue haphazardly, and it's up to you to tell it what strands and fibers are laid in the right direction and what is just fat that you need to kind of shed off. And your body will do that naturally if you move it slowly, load it a little bit, provide some kind of stress so that it can form like a diamond under pressure, right? As opposed to just pancaking on scar tissue and hoping it's not going to re-tear, which it will. But also to train your neurology too, so you have some of that joint sense and proprioception throughout the recovery process, because you want to rehab it to be resistant to stress, right? And so you need to apply stress accordingly. The only problem is that's a complex task for a lot of people, and it's a lot less liability to just put someone in a brace so that they're not back in their office because they don't know what they're doing and they re-injure themselves. And so the reality is you kind of want there to be an expert in your corner if you have a serious injury, because you're not going to know what is appropriate loading.
That's a great point. So what you're basically saying is that whole rest ice compression elevation is crap. You heard it here first, people.
Yeah. Not first, that's for sure.
Not first. Yeah, like rest is garbage. Icing's been absolutely smashed in the literature too, right? Like you don't necessarily have to ice too many.
I never tell anybody to ice.
Yeah,
it's like, all right, if you want to get out of pain real fast, maybe.
Yeah, and in some cases maybe it's beneficial, but there's a lot of negatives to icing too. Slow metabolic rate, tightening the tissues, less elasticity. Anyway, so my thing is so I get their point, right? The physician says, holy crap, like this is a liability thing. I've got a multi-million-dollar player, theoretically, right? Always theoretically. Multi-million-dollar player that I need to make sure gets back on the ice, and they're giving it 8 weeks. They're saying, okay, you'll be back in 8 weeks, right? And theirs is a liability thing. Look, if I don't have this person in a brace and they go and valgus stress their knee, or they catch their foot on a little bit of gravel or something in the rug or whatever, and all of a sudden they valgus stress, they tear that again. We're effed. Right now we're back to square one. Okay, I 100% get that. But after 3 weeks, these players, you evaluate them and they've lost a massive amount of muscular development in that leg, right? Like the quad is just atrophied, and they've lost balance, neurological control, movement patterns, right? Proprioceptive control. And man alive, it's a hell of a rehab to get it back, right? Mm-hmm. And so you weigh the stability versus mobility piece, right? And I get it, you want to stabilize it, but man alive, like Matt, you said it, like you need to be, it's protect and optimally load, right? So you need to absolutely get that leg moving, because an Olympic athlete will lose 1% per day with inactivity. You lie on the couch for a day, 1%, like that's fast, man.
That's pretty quick.
Do it for 3 weeks.
Yeah.
Right? And so there's nothing left. There's even like, you could even if they're in the brace, they should be on a bike pedaling the other leg, because there's a
crossover.
Yeah, there's a crossover of that benefit to the other leg. You know, that's wild too. But anyway, so my thing is theoretically, I would have the patient not wear the brace. So I would have them actually not true. I would have them wear the brace when they're not at home. When they're at home and in a completely controlled environment and they can control their motion, and you have emphasized what needs to not happen, you cannot allow your knee to collapse immediately. You cannot allow that. And get them to start just standing on the one leg for 30 seconds, you know, with arms basically right on the countertop, ready to hold you, and then have them just walk upstairs, you know. First would be the non-injured leg, then the injured leg follows, non-injured, and then non-injured leg, non-injured, you know, you just progress going from, and then finally you go from up to downstairs. But you have to do these simple types of exercises just to maintain the health of the tissues in there, and then you don't get the fatigue, right? And then after 3 weeks, you've got a nice state, and getting therapy, like, you know, things like grafting and myofascial work, and you know, like all those things that help align scar tissue, fantastic. And I'll throw it theoretically. After 3 weeks, they're kicking it. They're feeling great. They're like, I don't even need a brace anymore. As opposed to after 3 weeks, there's like, you know,
start from scratch.
Well, and they're all
Even
like
worse.
They're atrophy. Yeah, it's awful. And no wonder it is an 8 week, right? As opposed to you get these guys back in 3-4 weeks, right?
Yeah.
Mm-hmm. Like, that's amazing. And then, you know, I have so many guys in the NHL that wear knee braces because they had like even a grade 1 of an MCL, and they wear a knee brace prophylactically now. Why?
Yeah.
Like, why? Like, rehab it. Make your body, right? And again, I've had a whole bunch of them too that we've rehabbed, and they don't wear a brace anymore, right? Just collects dust in their closet. And they're healthy, and they're fit, and they're moving, and they're back at it, and they're performing great. And there's no increased risk for injury. But you have to get moving with it. So, yeah, I get the stability. I totally get it. It's a liability piece. They have to do that. 1,000%. A multi-million-dollar athlete, we can't have them re-injuring this, and then because now, well, how does that look on me, and how does that look on the liability side? We need to get this asset back in the ice. And from my side, I'm not the person in control making the decisions, so I want to see that athlete get back on the ice and not have to wait 8 weeks, like save them a month of rehab, right, and not have them atrophy. So I'm protecting, not really loading. Right? Yeah, I have some responsibility on my side, but it has to be very clear how they need to control their movement patterns, right? As soon as they walk out of that house and they're going into an uncontrolled environment, you have to be wearing that brace. You cannot allow that medial stress, right?
And it really has to be stressed, just like you put it, where it's like, if you're feeling good, sure, but there's a very clear silver lining here.
Matt, I love your comment is that you need to have an expert in your corner working with you. You need to.
Yeah.
I tell you what, having that expert in your corner working with you, man alive, can you ever fix these things up appropriately?
And here's an example of people that you probably know somebody like this who sprained their ankle, and they maybe put it in a brace or whatnot, a wrap. And, 8 weeks later, whatever, I feel good. But every single time I play basketball or I come down a curb, I roll it and I sprain my ankle again. It's chronically weak. And that's because you thought you healed from an injury that you didn't.
You just rested,
You just rested it, and now that's just scar tissue. And
well, they damaged the nerves, and then they never went back and rehabbed the nerves, right?
Yeah.
So you get that. So for our listeners, so if you stand on one foot, you'll see that your foot wobbles a little bit. If you slow that video down, you'll see that you're going to kind of fall to one side. There's a signal sent to the brain to say, hey, dummy, contract the muscles so you don't fall over. And then it goes down, it contracts the muscles, brings the leg back, maybe it goes to the other side. Oh, dummy, you're going to fall the other way. Signal sent to the brain, comes back down, contracts the muscles. And in real time, that's just a little wobble. And then when you sprain your ankle, like an inversion sprain, you kind of damage those nerves. And so now that reflex reaction becomes sluggish. And so now the next time that signal sent to the brain, hey, dummy, contract a muscle, you're going to fall over. By that time, your ankle's gone past anatomical integrity, and now you've resprained before your body can bring it back. So like you're saying, if all you do is stabilize the area because you've torn the ligaments too, and you go back, you haven't rehabbed the nerves, you're just going to keep going past anatomical integrity, right? So you've got to rehab the nerves. You've got to be doing balance exercises, right? That's that mobility versus stability piece. Yeah.
Absolutely. And I think I think the approach that we use with this like hypothetical hockey player, I think that's what really makes us different as a clinic, is that you could say that a lot of advice is like more conservative. It's like, oh, don't risk it. Try do what don't do anything for 6 weeks, 8 weeks, see how it is. And ours is quite a bit more aggressive in that let's kind of push the envelope and see what it is that you can do. And so like Dr. Greg's hypothetical rehab program, it's literally standing on one leg at first with you holding your hands out for balance. Like anybody can do that. I don't care how bad like the injury is. Like that will always benefit, and it's always better than doing nothing. And then you slowly just step it up. And the teams want the players back as quick as possible. They don't want to risk a worse injury and have them out 8 weeks, but like they do want them back in 3 or 4 weeks if that's possible. And so having an expert to help guide you through that program is super helpful, but like being aggressive with treatment, aggressive with rehab will get you the results faster, 100%.
And it will get you the results long term instead of having to start over every time you re-injure it, because you don't have the integrity in the joint and the body.
The last point I'd like to throw in there is that you keep saying having an expert in your corner, and it's so crucial for that, whoever that is, because getting an NHL hockey player back faster is pretty important, right? That's a pretty valuable asset that you're probably paying like whatever, 30, 40, 50, 60, $70,000 a game, right, to play. If you have a beer league, player that does that same injury in the final game of the season, and they're not going to be playing until next fall again, and it's beer league, you know what? It's fine to keep them in that brace a little bit longer, not as aggressively go at it. I've had athletes that, man, I got a year. We're in the Olympics in 3 weeks. We don't have the luxury of taking our time with this, right? And then I have other ones that's like, you know what? We're in the off season, and you're on 3 weeks of break anyway. Like, let's chill, and this just eases thing. But so it kind of depends on the individual circumstance too of how aggressively you go at these injuries, right?
Yeah, that's a good point. Play to your audience. How athletically inclined is this person? How well are they going to take to this advice and not perhaps overshoot it and re-injure themselves?
Yeah,
that would be starting all over again, and that's certainly not what we want. I think we tackled some really good stuff here, and this is totally so valuable for anybody listening, because everybody gets injured, but there's some important things to remember, and it's not necessarily public knowledge for everybody to have. So thanks again for listening. This is Move to Improve, and we really appreciate all the support. Take care now.